Assalamualaikum and good day. My name is Dr. Mardiana Abdulaziz from the Department of Pathology, UITM, and this is part 3 of the lecture, Inflammatory Diseases of the Gastrointestinal Tract. And this part of the lecture will cover the topics diverticular disease and peritonitis. At the end of this lecture, you should be able to describe the etiology, gross morphology, clinical manifestations and complications of diverticular disease, as well as the etiology, clinical manifestations, complications of peritonitis. So let's start with diverticular disease. What is diverticular disease? It is an acquired pseudo-diverticular outpouchings of the mucosa and submucosa. Pseudo-diverticular because the diverticulum does not involve the full thickness of the bowel wall, but it is only made up of the mucosa and the submucosa, hence the word pseudo. And it is typically an acquired condition occurring preferentially in the sigmoid colon, where they occur in between the tinea coli, which form the areas of weakness in the wall of the colon. And the pathogenesis is believed to be related to low fiber diet. So low fiber diet leads to a decrease in stool bulk, which then results in exaggerated peristalsis in order to propel the stool from proximal to distal part of the colon. And this exaggerated peristalsis leads to elevated intraluminal pressures in the colon, which then pushes mucosa into areas of potential weakness in the colon, forming a diverticulum. So if you take a look at the image here on the right hand side, you will see that there is invagination or outpouching of the diverticulum through the wall of the colon, via this area of potential weakness in between the tinea coli, where the penetrating vessels run through as well. In normal colon, you will find that the layers are intact, the circular muscle here and the discontinuous tinea coli, and this is where the penetrating vessels are. And in the setting of colonic dysmotility and or structural weakness, this is where diverticulum tends to happen. They invaginate in between the tinea coli, where the penetrating vessels are. So morphologically, this is the view from inside the lumen of the colon, and the arrows are showing some of the openings of the diverticula. So these holes are mouths of the diverticula, which are numerous in this particular specimen. On the outer part of the colon, on the serosa line surface, here you can appreciate the tinea coli, and this is, here's another band of muscle there, and this is the area of potential weakness we talked about earlier. So in between the tinea coli here, you have areas of potential weakness, and this is where the diverticula tend to occur. And on the outer part of the bowel, they confer this extensive sort of bulging and knobbliness to the outer wall of the bowel. Okay, as you can appreciate there. And on cross section, here we can see that this is an outpouching, or this is a diverticulum. This is the colonic lumen where the mouth or the opening of the diverticulum is, and this is where the cavity of the diverticulum is. And notice how the wall of the diverticulum is made up only of the mucosa and maybe a little bit of the submucosa, but in general the wall of the diverticulum is much thinner compared to the adjacent normal colon, which should have the full layers of the bowel wall, including the muscularis propria, whereas it's deficient in the diverticulum. So just to illustrate that again, histologically, if you do a cross section, then you can appreciate that the diverticulum will be composed of this pouch. Okay, so this pseudo-diverticulum, you have mucosa running through, penetrating beyond the muscular layer, and forms this sort of sac-like architecture at the bottom. So you have a mouth or the opening there, and this is the cavity or the lumen of that diverticulum. Okay, so that's grossly what it looks like, and this is what it looks like histologically. So majority of the patients are actually asymptomatic, but if they do have symptoms, then they may present with things such as intermittent cramping, continuous lower abdominal discomfort, constipation, diarrhea, or they may present with complaints relating to complications, which we will discuss in a minute. So the presentations are rather non-specific, and there is a wide differential diagnosis associated with these symptoms. In terms of complications, there are several complications of diverticular disease, and they can have various manifestations. So here are your colon, and this is the outpouchings, which forms the diverticulae. And if there is obstruction to the opening of the mouth of this diverticulae, then you can have inflammation, diverticulitis, and if that becomes severe with collection of leukocytes, leukocyte debris, extensive exudate, you can get abscess formation. So that's complication number one. And recall I said earlier that the wall of the diverticulum tends to be quite thin. Okay, so with inflammation, with obstruction, inflammation, there is increase in intraluminal pressure. You can get secondary mucosal ulceration, and this happens within a thin-walled diverticulum. So the diverticulum can perforate, and that can lead to peritonitis, and they can present with features of peritonitis as well as systemic effects of inflammation. On top of that, if the perforation of the diverticulum involves adjacent organs and a pathway or a connection is formed between these two organ kind of lumen or cavities, then that leads to what we call a fistula formation. So this can occur, say, between one loop of bowel to another, or in the image shown here, illustrated here, is a connection between the bowel, the diverticulum in the bowel with the bladder. So let's say if in this case, if you have a bowel bladder fistula, then patients may present with features such as passing fecal material within the urine. Complication number 4 is if there is erosion of vessels in the vicinity, then patients can have hemorrhage. And lastly, because of this persistent abnormality and persistent inflammation, patients can develop fibrosis and subsequent stricture or narrowing of the lumen of the bowel, and patients can present with symptoms of obstruction. Okay, so we move on to the topic peritonitis. So peritonitis refers to inflammation of the serosal membrane that lines the abdominal cavity and the organs that are contained within. There are several ways to classify peritonitis. You can divide them into primary versus secondary peritonitis. They can also be classified into infectious versus sterile, or in terms of distribution, whether it is localized or diffuse. When discussing whether peritonitis is infectious or sterile, there are also cases which show overlap, a mix kind of infectious as well as sterile irritant materials, and we'll discuss this in a little bit more. So when we talk about primary peritonitis, this is often referring to spontaneous bacterial peritonitis in the absence of an obvious source of contamination, and patients typically have cirrhosis and ascites. This is uncommon compared to secondary peritonitis, which is the most common type. And secondary peritonitis relates to a pathologic process in a visceral organ. And this can be in the form of either secondary to a perforated viscus, such as perforated peptic ulcer, for example, perforated diverticulum, necrotizing pancreatitis, trauma, pelvic inflammatory disease, etc. So, but it's often secondary to something else. So these are a very nice comprehensive image showing the various, I suppose, patterns of peritonitis, as well as some example of sterile peritonitis. So if we look at the top half left, okay, of the image, you can see that this is what generalized peritonitis should look like. So it essentially involves everything in the cavity that has peritoneal lining. So it involves the surfaces of the liver, the serous surfaces of the bowel, the mesothelial lining of the cavity itself, etc. But in contrast, if you talk about localized peritonitis, then you're referring to pockets of inflammation of the serosa, which can form abscess. So, for example, you can have subphrenic abscess. You can have peritonitis secondary to appendicitis, for example, or you can have peritonitis just localized in the pelvis, secondary to pelvic inflammatory diseases, etc. Top right shows you in terms of infectious peritonitis, there are several routes of bacterial invasion, which can be hematogenous. So let's say you have an infection somewhere and then you have bacteremia, and the bacteria can seed into the peritoneal lined cavity or spaces and cause secondary peritonitis. Or any perforated viscous such as peptic ulcer, ulcerative colitis, diverticulum, etc. can be a source of infection as well, because the content of the bowel contains a lot of bacteria, and this can be the source of infection. Other routes include perforating wounds, which may be either surgically induced or traumatic, or let's say here transtubal perforation of vaginal fornix or uterus. This can all provide source of infection leading to secondary peritonitis. Okay, in the box at the bottom here are examples of acute peritonitis due to irritating substances. So these can be sterile peritonitis, so they do not cause peritonitis because of infection, but the substance that spill into the abdominal cavity is irritating to the mesothelial or serosal lined surfaces. So these substances include things such as bile, which can occur, let's say, leakage of bile following gallbladder excision, for example, or pancreatic juice due to pancreatitis, or gastric juice because of perforated ulcer, or blood in terms of splenic trauma, for example. So these substances, they don't cause infection, but they are directly irritating the serosal surfaces. Okay? In certain conditions, such as in perforated gastric ulcer, initially when there is perforation, then the gastric juices spill, and the gastric juices are irritant to the serosal lining, and subsequently bacterial infection can supervene. So this is an example where you can have both infective and sterile peritonitis going on at the same time. Clinical manifestations and complications of peritonitis can be non-specific, but there are some features that can be quite suggestive. But first of all, you need to make sure that when you take history, you cover all the risk factors, any diseases that might predispose to peritonitis, any recent surgery, for example. Patients can have fever, chills, anorexia, nausea, vomiting, but probably majority of the patients will have abdominal pain, which can be quite severe, can be exacerbated by any movement, and may be generalized. In extreme cases, patients may be distressed and may even present in shock. Clinically, when you do examination, they are usually very tender to palpation, and presentation may also be related to the cause of the peritonitis. So, for example, in penetrating trauma, so patients present with penetrating trauma, but when you examine the patient, then you notice they have secondary peritonitis. So you have to have a high index of suspicion in this case. And of course, the most feared complication will be sepsis and potentially death. Okay, so the references for the two topics that I used were Robbins' Basic Pathology 10th edition, Underwood's Pathology 7th edition, and also eMedicine on the topic of peritonitis and abdominal sepsis. Thank you very much.